Good afternoon, students.
गुड आफ्टरनून सर.
Very few
सर
students.
तुम्हाला
बोला.
ते काल पीसीआयचा फॉर्म फिलअप करायचा आहे ना आपल्याला.
हो.
तर रजिस्ट्रेशन वगैरे झालं, पण ते कोर्स डिटेल मध्ये ना तिथे आम्हाला बी फार्मचं पण विचारताय. ते फिलअप केल्याशिवाय सबमिटच नाही होते. तिथं काय टाकायचं ते कळत नाहीये.
बरं. काय कर, तुमच्यातलं इथे जो लोकल राहत असेल ना, तो इथे या, इथल्या कम्प्युटरला एखादा बघा काय होतं ते. इथे अमरावती
ओके.
आम्रपाली मॅडम आहेत पी सी आयचं बघणाऱ्या. आपण
हा
त्यांचं
ठीक आहे.
गायडन्स घेऊ, किंवा असं काही असेल ना तर
हा
आपण त्याचं जे आहे पी सी आयचं जो आय टीचा आहे त्याला आपल्याला
हा हा
पाठवावं लागेल इन्फॉर्मेशन.
हा. कारण की ज्युनियरचा पण कॉल आला मला, त्यांना पण तोच प्रॉब्लेम येतोय.
हां, ते करू ना तसं. मला ते आदित्य वगैरे आला होता मेसेज, म्हटलं टाकून बघ, नंतर मुलांचा काही आला नाही.
बर बर चालेल.
तर मी आम्रपाली मॅडमला विचारतो काय करायचं ते.
हो ठीक आहे.
तर एखादा तुमचा जो लोकल स्थानिक राहत असेल ना,
हा
तो या, म्हणजे त्याचं मेल आय डीवरनं आपण उघडूयात आणि बघूयात काय करता येईल ते.
ठीक आहे चालेल.
हां,
हो.
ओके. So next topic what we are going for is this fungi. We have started with it. We have seen that there are differences between other microorganisms and fungi, because fungi are that way multicellular at most of the times. Rarely they can be unicellular, and they have many structural differences than bacteria. They are more closer to the human system, and therefore the treatment is a problem, and therefore the adverse effect chances are more. So let us see one by one what are the specific thing. We have seen all this, that it is cell wall is composed of chitin, that is N-acetyl glucosamine. The bacterial cell wall is composed of peptidoglycan, so this is difference. Second is it contains ergosterol, while the human cell membrane is having cholesterol, and therefore the differences are there. We have seen that most of the drugs are acting on ergosterol in earlier class we have seen, and because of that ergosterol is not properly synthesized, and therefore it affects the cell wall strength. So fungi have a nucleus and a well defined nuclear membrane, and it is also having chromosomes. They are eukaryotic organisms, and they live as saprobes or parasites. They are complex organisms in comparison to bacteria. Bacteria are prokaryotic, and just like human beings, fungi are also eukaryotic. They have no nuclear membrane. Bacteria, they don't have nuclear membranes and no mitochondria. Therefore, we have difference with this. Here, fungi have everything. Just a minute. Hello. Huh. Huh. अच्छा. अच्छा. यांच्याकडे होते ना, या लोकांनी देताना कमी जास्त केले काय? एकच ग्रुप होता ना तो. त्यांना विचारून घ्यावं लागेल तुम्हाला. हां, येस सर, येस. ओके. So these antibacterial agents, they are uh, not effective in fungal infection because of these differences, and therefore, and also antifungal agents are not effective in bacterial infection. So we have a different class of these. So we'll see the structure, and we'll see how various drugs are acting. So polyene are the agents which will get integrated into the cell membrane, and thus it will reduce the strength of cell membrane. Then 5-fluorocytosine will be causing interruption of the DNA and RNA synthesis. Azoles are the drugs which will cause interruption of sterol biosynthesis, that is ergosterol synthesis, and also it will affect the mitochondrial membranes, and because of that the membrane's strength will be reduced, and thus it will become less what we can say strength wise, and can rupture easily. So there are fungal infection, we call them as a mycosis. Whenever there is a fungal infection, we call it as a last lecture also we have seen it. And we can have various kind of infections. Superficial infection which are affecting skin, nails, scalp or mucous membrane, they are superficial one. Then it can be systemic infection which are affecting deeper tissues and organs. Superficial fungal infections, they can be classified into dermatomycosis and candidiasis. Candida, that we have seen earlier, that is the Candida species is there, and that is as such Candida albicans is one of the very prominent in this. So it is commonly present as a normal flora of mouth, skin, intestine and vagina, and it is controlled by the microbial flora which is present. So when any antibiotics we take, then that may cause destruction of this microbial flora, and this microbial flora, if it is not there, then this this candidial fungus can growth and can cause, we can call it as a super infection. We have seen it earlier during general considerations. So this is a problem, and it becomes opportunistic, which is otherwise non-pathogenic. It is present in the body but becomes pathogenic and can cause infection. Dermatomycosis, they are infections of the skin, hair and nails. They are caused as dermatophytes, and the commonest are due to the tinea organism. There are many tinea which are also known as a ringworm. Now this is very important. Again, here I like to put and just pay an attention that tinea pedis and so many tinea species are there. Tinea pedis is one of the very common in that, and ringworm word is used, but see when we will see anti-enthalmatics, their worms are there. Here this is not worm. This is although we call it as a ringworm because it is an infection, it is an old nomenclature, it is called as a ringworm. Very famously nowadays, if you have seen very advertisements of some BTEX or something like that, that Kaj Khujli, like that, this there. So these are all fungal infections. It's a circle-like thing is there that comes, and in that circle the infection is there, and very strong itching is there. So that is called as a tinea species, and this is the ringworm infection. Now this ringworm, I repeat, they are not enthalment. Here these are not helminth class, it is a fungi class. Otherwise all other worms we are having, they are in the helminth class. They are when we shall go for that, we will find that as these are the anthelmintic drugs we are using to treat their infections. Rather we call them as infestations, because infection we usually reserve for bacteria, viruses which are smaller one, and the higher species we use word infestations. So in that cases it is used. In superficial candidiasis, the fungus candida infects the mucous membrane of mouth, that is oral thrush, or the vagina, it is called as a vaginal thrush, or the skin. So we have got again systemic infections that increase systemic candidiasis, cryptococcal meningitis or endocarditis, pulmonary aspergillosis, blastomycosis, histoplasmosis, then coccidioidomycosis, then paracoccidioidomyosis, etc. These are various infestations they are caused. So you can see pictures that shows chronically how it becomes, that is buccal mucosa and tongue, how these fungus are there, and acutely how redness and some infection is there. So chronic and acute shows differences into it. These fungal infections, whether they are superficial or systemic, they are common in the patient with the weak immune system, like patients with the AIDS, then debilitated patients, patient underwent organ transplantation or immunosuppressants, patients which are on the anti-cancer treatment, they are having more chances to have it. Now what are various drugs? Again we can classify antifungal drug on various ways. We can classify on the basis of mechanism of action, which we have done earlier. We have classified them acting at recently, just now in figure only we have classified that acting on ergosterol synthesis, acting on DNA, acting on mitochondria, isn't it? So this is one way of classification. Another is the chemical classification, that is what is the chemical structure they are having. So let us have one way now, that is we are doing it chemically here, but yes, simultaneously we can have pharmacological or on the basis of mechanism of action classification. So polyenes, they are polyene macrolide antibiotics. Example of these are amphotericin B, nystatin and natamycin. They are binding to the ergosterol in the fungal plasma membrane that leads to formation of pores, and this causes increase in the permeability of the membrane. Therefore, there is a leakage of intracellular. Everybody is facing same. Because it should not be. I am using the wired net. It is not a telephonic net. So I think Akshay might have got a connection problem. I don't think others are having. Everybody is having this. Akshay. All others. Okay. They bind selectively to ergosterol in fungus but not to the cholesterol, and therefore they are selective. This we have seen earlier. So this is how they are acting. Amphotericin B that will interact with the hydrophobic ergosterol, and thus it will affect the transportation. The potassium and other small molecule will be lost through the pore and it will cause cell death. Why there is a resistance to this polyene? Because of the decrease in the ergosterol content of the fungal membrane and change in the binding intensity. The binding capacity will be reduced and therefore they will not able to affect the ergosterol. Then next class is there are two types of azole. There are two chemical structures, that is, one is imidazole structure and another is triazole structure. In imidazole we have got ketoconazole, miconazole, cotrimazole. These are the drugs, while here it is fluconazole, itraconazole, voriconazole. These are three. See, very important again, let me tell you, or you can remember it. These names are very similar. If you remember, during amoebiasis or protozoal infection, the important drugs were metronidazole, tinidazole, secnidazole, etc. Here the drugs are ketoconazole, miconazole, fluconazole, itraconazole, voriconazole, cotrimazole. Here also azoles are there. Then next is when we will go for helminthic drugs, we will find again there are also similar drugs, that is albendazole, mebendazole, etc. So particularly if it is MCQ type of question, then you should be very careful about it, which drugs are useful in what. Structurally they are very similar. This is only place where almost similar name have different utility. Otherwise, so far you people might be having an habit that whenever the drugs are there, example enalapril, ramipril, fosinopril, so all pril or candesartan, irbesartan, telmisartan, so they all are a similar drug. Here it is a different. Here the drugs are totally different, and you have to remember this. So what is the mechanism of action of these drugs? They are fungistatic. They inhibit the cytochrome P450 demethylase enzyme, and that enzyme is important for the formation of ergosterol. So this is also affecting the ergosterol synthesis. This inhibition disrupts the membrane structure and function, and thereby it inhibits the fungal growth. Mechanism of resistance to azole: mutation in the gene which encodes the demethylase. Alkylamines, example of these are terbinafine, naptipine, butenafine. These are alkylamines. They are very active newer analogues. They inhibit the fungal squalene epoxidase, a very important enzyme for the synthesis of ergosterol. This and accumulation of toxic amount of squalene, because this squalene epoxidase enzyme is inhibited, therefore squalene, which is the main starting material for that reaction, will be accumulated because it will not be metabolized, and this toxic amount of squalene will result into the death of the fungal cell. Significantly higher concentration of terbinafine are needed to inhibit human squalene epoxidase, which is the enzyme which is required for the cholesterol synthesis pathway, and Therefore, there is a selection or there is a selectivity or therefore it is toxic in fungi. But again, we should remember that most of the antifungal can be toxic to human being because most of the things are comparatively more similar than that of bacteria. In bacteria, the similarity was very low. Then next kind of drug is caspofungin, that is we call them as a echinocandins. So in this echinocandin, the drug is caspofungin, micafungin, anidulafungin. These are various drugs which are there in this class. These echinocandins, how they act, they interfere with the synthesis of the fungal cells. Cell wall, they inhibit the synthesis of D-glucan that leads to the lysis and the fungal cell death is the reason. Then the antifungal drug which inhibits the mitosis of the cell. You know, mitosis is very important step in the cell division. So this griseofulvin is the drug which will inhibit this mitosis. Mechanism is it will inhibit the fungal mitosis by inhibiting the mitotic spindle formation. If you remember all this microtubule and because of that centromeres they are separating, and because of all this so it binds with the tubulin, it will interfere with the microtubule functions, and thus it will inhibit the mitosis. Then next class of the drugs which will inhibit the DNA synthesis, we call them as antimetabolites. If you remember this word we discussed earlier also, antimetabolite, that is even during PABA, during sulfonamide, this was the because it was the first antimicrobial we studied at that time, we discussed it as a this class is antimetabolite. So antimetabolite means they compute for the normal metabolic process, but and therefore the enzymes they utilizes this drug instead of the normal precursor, and they form the product which is not as per the normal situation, and because of this abnormality the cells they either cannot grow, that is static function, or they die because of that, that is bactericidal or cidal function we will call. So drug is here flucytosine, that is 5-fluorocytosine is also called as a 5-fluorocytosine. So this drug will enter the fungal cell by perimase, which is enzyme which is not present in the mammalian cells. It is then converted by the series of steps to 5-fluorodeoxyuridine 5-monophosphate. If you can understand, this is a pyrimidine molecule similar to that of the nuclear pyrimidines, and this false nucleotide will inhibit the thymidylate synthetase. Because of that, thymidine will not be there, and thus fungus will be deprived by thymidalic acid in the essential DNA component, and because of that there will be change in the DNA structure, and that will not be a normal one. This mononucleotide is further metabolized to trinucleotide, that is 5-fluorodeoxyuridine 5-triphosphate, and it is incorporated into fungal RNA, and thus it will disturb the nucleic acid and protein synthesis. Amphotericin B will increase the cell permeability, allowing more fluorocytosine to penetrate into cell, and they are very synergistic, therefore fluorocytosine and amphotericin B are combined together. So this is how it is acting. This is a fluorocytosine which is having similar structure to that of pyrimidines which are normally present. The amphotericin B, if it is given, then it will increase the permeability. Fluorocytosine will enter and it will be utilized by the same enzymatic process, and thus it will converted instead of uracil it will be converted into 5-fluorouracil. This 5-fluorouracil will be deoxyuridine monophosphate and triphosphate like that, and they will be then affecting the synthesis of pyrimidines, like that is thymidylate, and that will cause the problem. Then amphotericin B is a polyene macrolide antibiotic which is poorly absorbed orally. It is useful for the fungal infections of the GIT. The drug of choice for the most systemic infection, that is given as a slow IV infusion. It is locally used in the corneal ulcers, arthritis and bladders irrigations. It can also be given intra-arterial and locally. It is penetrated through blood-brain it is not good permitted through blood-brain barrier, but it can be increased in the meningitis. A similar thing we have observed in streptomycin also. Pharmacokinetic changes that whenever there is a inflammation or meningitis, then its crossing to blood-brain barrier increases. So this is rather good feature, particularly when it has to be used in the meningitis, that other condition it will not cross, it will not reach to brain, so no adverse effect on the brain it will able to cause. And when there is a meningitis, then it will cross it more, and thus it will able to act. The excreted slowly via kidneys. The traces are found in the urine for months after cessation of drug. Half-life is 15 days. So this has minimal penetration into CNS, vitreous humor and amniotic 1. Topically can be applied, and it can be given by intravenous injections. The side effects of amphotericin, they are more serious, is renal toxicity. It occurs to around 80% of the patient. Then hypokalemia in 25% of the patient, hypomagnesemia, anemia and thrombocytopenia, impaired hepatic function. These are important adverse effects the drug is causing. Then anorexia, nausea, vomiting, abdominal, joint and muscle pain, loss of weight, fever, anaphylactic shock are there. These are the various adverse effects. Comparatively, it has got more toxicity than other antifungal compounds, but it has got very powerful actions also. It is more active at various conditions. Then amphotericin B is packed in a lipid associated delivery. We call it as the liposomes, and these are targeted effectively towards the fungal infection, and thus we can reduce the toxicity to the nephron. The Pauline macrolide, another is an statin. It is similar in structure with amphotericin B. It has got same mechanism of action, that is bind with the ergosterol, leading to formation of pores, and because of that the material gets out of that. It is too toxic for systemic use. It is not used for the systemic. It is not absorbed from GIT, skin or vagina, therefore administered orally to prevent or treat superficial candidiasis of mouth, esophagus or intestinal tract. There only it can be applied locally. So it is given in the form of units, that is 1 lakh unit or 5 lakh units are given 4 times a day, or tablets of 5 lakh units are used to decrease GIT colonization. Remember here, it is not for systemic, but it is for the GI only, because it will not be absorbed from GIT, therefore it is used for the GI infections only. Then lastly, natamycin is the macrolide Pauline antifungal that is used to treat fungal keratitis, infection of the eye. It is effective against aspergillus and Fusarium corneal infections. It is effective in Candida, Cephalosporium and Penicillium. It is not absorbed when given orally. It is available in cream and ophthalmic eye drop. So it is only for these local activities. Then flucytosine is useful against Candida and Cryptococcus. It is a synthetic pyrimidine antimetabolite. It is often used in combination with amphotericin B. Very good one, fungistatic, effective in combination with itraconazole also. Then treating, that is for treating chromoblastomycosis, and with amphotericin B for cryptococcosis. In that it is used. It is highly effective in the cryptococcal meningitis in the AIDS patients. So we have seen the mechanism, how there is a synergism with these two. It is absorbed rapidly well from GIT, widely distribution in this body, penetrate into CSF. What are the adverse effects of flucytosine? It is reversible. Neutropenia it can cause, thrombocytopenia and the occasional bone marrow depression it can cause, nausea, vomiting, diarrhea, severe enterocolitis, It causes reversible hepatic enzyme elevation in 5% of the patients. Ketoconazole is the first one in the azole. This was the older one. It was the first orally active narrow spectrum azole was available for the treatment for the systemic mycosis. It acts by inhibition of ergosterol synthesis. We have seen all the mechanism of azoles earlier, imidazoles and triazoles. These are two types of azoles. It is well absorbed orally as an acidic environment favors the dissolution. It is only administered orally. Viability is decreased when the H2 receptor blocking agent means acid is very important for that, or any agent which reduces the acid will cause decrease in the absorption. It is 84% bound to plasma protein. It does not enter CSF, so it is not useful in the brain infection. Metabolized extensively by liver, that is cytochrome P453A4, and is inactive metabolites are excreted in bile. Anything that is metabolized by CYP450 can affect the efficacy of this. Example, enzyme induction by rifampicin will reduce the blood concentration because it will increase the metabolism. Some of the drug will inhibit the microsomal enzyme, will inhibit the metabolism, so it will increase the toxicity. It is active against many fungi like Histoplasma, blastomycosis, then Candida, coccidioids, but it is not used or it is not effective against Aspergillus species. It is available as tablet, cream and shampoo dosage form. The shampoo and aerosol forms containing are highly effective in treating seborrheic dermatitis or dandruff. It is useful in. Ketoconazole inhibits the adrenal and gonadal steroidogenesis, that is cortisol, progesterone, testosterone, they are affected, and it causes menstrual irregularities in the female, loss of libido, impotency and gynecomastia in males. Gynecomastia means female-like characteristics in male. So these are the various conditions which are there. Ketoconazole could also be used in the management of Cushing syndrome and cancer of prostate because it affects the hormonal secretions. It will reduce the hormonal secretion. So it is adverse effect is used as a therapeutic use. Ketoconazole side effects, that is dose dependent nausea, anorexia, vomiting, liver toxicity, hair loss it can cause. It inhibits the steroid biosynthesis. It causes endocrinal abnormalities like we have seen menstrual gynecomastia, decreased libido, impotency, etc. It causes fluid retention and hypertension. It is contraindicated in pregnancy because of its various adverse effects there. It has got many drug-drug interactions, that is because it inhibits cytochrome P450, so it can affect cyclosporine, phenytoin, tolbutamide, warfarin. These are some of the drugs of which metabolism it will be inhibiting, and therefore their concentration will increase, can become toxic. Cyclosporine and phenytoin will inhibit its metabolism and it will increase the ketoconazole toxicity, and because of this both each other increasing each other's concentration, the inhibition will be more. Warfarin rifampicin increases its metabolism and hence decrease the concentration. We have already seen that anything which is affecting acid will affect its absorption. So this is another issue. So the drugs should be given when maximum acid is there and no antacid is used. Then cyclosporine, phenytoin, tolbutamide, warfarin, they will cause increase in the concentration because of the enzyme inhibition. Ketoconazole decreases ergosterol in fungal metabolism and it reduces the fungicidal action of amphotericin B. So they should not be combined together because ergosterol is reduced and amphotericin binds to the ergosterol. So if ergosterol is reduced, then there are less binding sites to amphotericin B and therefore they are not used. Then the newer agents are there, that is triazoles like fluconazole, itraconazole, hocorianazole. They are newer agents and less toxic and more effective. They damage the fungal cell membrane by inhibiting enzyme demethylase. It is also necessary for ergosterol synthesis. They are selective, they can penetrate to CNS, they are resistant to degradation, and they causes less endocrine distress, although they are also causing, but they are causing less comparative to ketoconazole. It is completely absorbed from GIT. They are excellent viability by oral route. They can even cross blood-brain barrier, and even good concentration in cerebrospinal fluid they can have. Then concentration in plasma is same by oral or IV route. Viability is not altered by food or gastric acidity. It has least effect on the hepatic macrosomal enzymes. Drug interactions are less common with these, and therefore these are comparatively more safer drug. Fluconazole easily penetrates to CSF and considered as a drug of choice in the cryptococcal meningitis and coccidioidomycosis. It is unique that it can act in that condition also. It is safely administered prophylactically in the patients receiving bone marrow transplant, because during that we have recently, this year only we have studied that during that we have to give immunosuppressants. Because of that immunosuppressants, this fungal infection can be there, which otherwise should not have been there. Resistance is not a problem. Expect patients with the HIV, and there is the drug is excreted in renal one. It is used in candidiasis, cryptococcosis, in AIDS. Then it is used in coccidial meningitis, where it is drug of choice. It has activity against histoplasmosis, blastomycosis, spirotrichosis, and ringworm. But itraconazole is better in same dose for this ringworm infection. Not effective in aspergillosis. Side effect: nausea, vomiting, headache, skin rash, abdominal pain, diarrhea, reversible alopecia. No endocrine adverse effect. Hepatic failure may lead to death, and it is highly teratogenic, so should not be given during pregnancy. It is a new synthetic triazole, that is itraconazole. It lacks the endocrine side effect of the ketoconazole. Has a broad spectrum activity. It is administered orally as well as intravenously. The food increases the absorption, so should be given with food. Itraconazole is extensively metabolized in liver by cytochrome P450, that is CYP3A4. It is highly lipid soluble. It is well distributed by bone, sputum, and adipose tissue, highly bound to plasma protein. It does not penetrate CSF adequately as compared to fluconazole, therefore its concentration is less to treat meningeal fungal infections. Itraconazole steady state reaches in 4 days, so loading doses are recommended in deep mycosis. Intravenously reserved only in serious infections. Side effects of itraconazole like nausea, vomiting, hypertriglyceridemia are there. Hypokalemia, increased aminotransferase, hepatotoxicity, and rash are the adverse effects. The drug is withdrawn whenever these adverse effects are there. Next are the horiconazole. It is a new drug available in oral and IV doses, similar to itraconazole. High biological activity when orally. Hepatic metabolism is predominant. Inhibition of P450 is less than the other one, that is ketoconazole. Reversible visual disturbances it can cause. Then still newer is a posaconazole. It is a new broad spectrum antifungal agent similar to itraconazole. It is approved to prevent candida and aspergillus infection in severely immunocompromised patient and for the treatment of oropharyngeal candidiasis. It can possibly used in the treatment of fungal infections caused by mucormycosis and other zygomycetes. In that, these are very typical where this can be used. It can be given orally and it is well tolerated. It can cause elevation of liver function test and it inhibits cytochrome P450. Side effects are gastrointestinal, that is nausea, vomiting, diarrhea, abdominal pain, and headache. These are various side effects. The new class of drug, that is echinocandin class of antifungal drug, in that the caspofungin is the drug that is interfering with the synthesis of fungal cell wall by inhibiting synthesis of beta D glucan, which is a major constituent of the fungal cell, and because of that it affects the cell membrane. Useful for aspergillus and candida, not orally given. It is not active orally, given intravenously, high bound to serum proteins. It is slowly metabolized by hydrolysis and N-acetylation, eliminated equally by urine and fecal route. Even though it is given intravenously, it is appearing in the feces. That means there is a enterohepatic this one, that is, it is taken up by liver and excreted in the intestine. It is very expensive new drug. The drug which are used for cutaneous mycotic infections, topical cutaneous means skin diseases. So topical antifungal preparations, they are applied topically to the treat superficial infections, like topical azole derivatives, nystatin and amphotericin B, tolnaptate, terbinafine, they are used. Oral agents also used for topical infection, but they can be used orally, because if we feel that the topical use it not giving good response, then can give oral one. Example of these are oral azoles, griseofulvin, terbinafine can be given by oral route also apart from topical. So topical azoles are miconazole, cotrimazole, butoconazole and terconazole. They are topically active, they are not given orally, they are rarely administered and parenterally because they are having severe toxicity. Their mechanism of action and antifungal are same as those of ketoconazole. They are associated with the contact dermatitis, vulvar irritation, edema. Miconazole is a potent inhibitor of warfarin metabolism, and it can produce bleeding in the warfarin treated patient even when it is applied topically. So powerful is there, because from topical it is absorbed to the blood, and from blood it will go to liver and it will cause inhibition of metabolism. No significant differences in clinical outcome is associated with any azole or nystatin in the treatment of vulvar this one. Next is tolnaptate. It is effective in most cutaneous mycosis. It is ineffective against candida. It is useful in the tinea pedis, that is foot fungus. Cure rate is around 80%, which is a very good one. Exact mechanism of action is not known, but it is felt that it is believed that it inhibits the squalene epoxidase, which is an important enzyme in the biosynthesis pathway of ergosterol. It is available as cream, gel, powder and topical solution. So this is only for topical use and no systemic use. Griseofulvin largely replaced by terbinafine for treatment of dermatophytic infection of the nails because of the toxicity. It is very insoluble in water. It is useful for dermatophytes. It is fungistatic for species of dermatophytes and has very narrow spectrum. It interacts with the microtubule function and hence interfere with the mitosis. So we know how it is. We know that how centromeres are there, how microtubules form that, and then how spindle is formed. So if it is affected, then cell division will be affected. Very typical about griseofulvin that its absorption increases with the fatty meal. It is always given with the, therefore, and it should be a micronized form of griseofulvin. Very finely particled griseofulvin is there, which is given with the lipids like oil or such oily material is there, fats are there, or butter something is there. With butter, anything which is very fatty. With that it is given. Barbiturate decrease the absorption from GIT. It is ineffective topical in it has to be given orally for the treatment of hair and the nail dermatophytic infection. It does not inhibit the fungus that is already formed. It only do not permit growth of fungus. The drug has to deposit first in the keratin of the growing skin, nail and hair to get rid of the disease. Treatment is required for around 1 month for scalp and hair ringworm, 6 to 9 months for the fingernails, and at least 1 year for the toenails. So this is how much it is taking. Treatment depends on the time that our hair and nails need to reach the full growth. So extensively metabolized in the liver and it induces cytochrome P450. There are various metabolites up there because of that. So it is used in the mycotic diseases of skin, hair and nail. It is highly effective in the athlete's foot It is not effective in subcutaneous or deep mycosis. Griseofulvin side effects, that is there are headaches, peripheral neuritis, lethargy, mental confusion, impairment in the performance of the routine task, fatigue, vertigo, syncope, blurred vision. These are some of the important adverse effects. Uh, Terbinafine is a synthetic alkylamine. It is the drug of choice for treating dermatophytes. As compared to griseofulvin, it is better tolerated, requires shorter duration of therapy. It inhibits the fungal squalene epoxidase, decreasing the synthesis of ergosterol. The fungicidal but activity is limited to Candida albicans and dermatophytes. It is effective for the treatment of onychomycosis, that is fungal infections of the nail. 50 milligram daily for 6 weeks for fingernail infection, and for 12 weeks in the toenail infection is normally treatment. It is well absorbed orally, viability decreases due to first pass mechanism. Protein binding is more than 99% in plasma. The drug is accumulated in skin, nails and fat. It is severely hepatotoxic and it can cause liver failure, which can cause death. The half of the terbinafine is 12 hours is a half life, but terminal half life is goes to around 200 to 400 hours. That means it is slowly released from the tissues because it is deposited into tissues. It can be found in plasma for 4 to 8 weeks after prolonged therapy. It accumulates in the breast milk and therefore should not be given to the nursing mother. Metabolites excreted in the urine and its clearance is reduced in the moderate and hepatic impairment. Not recommended in the azotemia or hepatic failure. What other adverse effects are GI disturbances, taste and visual disturbances, allergic reactions, transient rise in the serum liver enzymes. Rifampicin will decrease the metabolism of it because of the enzyme induction, and the cimetidine will increase its concentration because of the inhibition of cytochrome P450, and thus this drug interaction has to be taken care of. So this is how we completed our antifungal topic. If you have any difficulty, please go through it and you can report it whenever you read it. We can, if you wish, we can solve the difficulties.